Today's episode of the Gestalt Education Show is brought to you by three of our favorite sponsors: Human Locomotion, Core 360 Belt, and Dynamic Disc Designs. All the information can be found below. By now, you have definitely heard us talk about them, so check out the show notes, click the links, use the codes, and make sure you support our favorite people. As always, we got a great episode lined up for you today, and thanks for tuning in. All right, everyone. Welcome to another episode of the Gestalt Education Show. Today we are at Casa de Winchester poolside, Brett. So
we're really on home base now.
Yeah, that's right. So thanks for inviting us over. And today we have one of our recurring guests, a very, very special guest. So all the way from the Czech Republic, from Prague, Marcela Safarova. So we are so delighted to have you here. You've been here all weekend for the DNS Pediatrics 1 course, and we've kind of done some interviews throughout the weekend that have kind of been based all on pediatrics and on your teaching. And I always say, like, I took a lot of DNS courses before, and I've been lucky enough to learn from Brett and a lot of amazing DNS instructors. But until I sat through your DNS Pediatrics 1 course, it really put everything into perspective for me when it comes to DNS. And I think that's one of the topics that we're going to talk about today, which is kind of the common mistakes that parents make, that we make as practitioners, that basically get our patients and get our pediatric patients into the problems that they have later on in life. And so there's a lot of complex neurology and a lot of other things that we've already talked about really extensively on this podcast. And so today's not necessarily about that. Marcela asked for just like a little chill podcast, and we are happy to oblige. And so she's taught for 3 straight days, and we're super happy that she decided to do this. But we bribed her with a really good bottle of wine, which you can see sitting over here by Brett, which is, Brett, you want to talk about it?
Moonside, which we've dreamed about having this bottle for a while. So it's Howell Mountain, little mountain fruit, and we got it for the Congress, but we never got around to drinking it because I don't know why.
We were so blown out by the end of that weekend that we were done. So yeah. We were tired of seeing each other, and we just needed a break.
Yeah, we just needed a break. So yeah, we got that open, and I think too, the Western part of the world, we do a lot of things wrong in that first year of life with our children. You know, like from what we put on their feet, from how we handle them, from what we feed them, from, I mean, we do a lot of things that, you know, we could do better. And I always think it's ironic because as a parent, you would never knowingly do something that could potentially harm your child. So I think there's no one better in the world than Marcela to basically talk about what are those things. Maybe we'll start off with, what are the most common mistakes that get made in the first year of life from the parents in the handling?
Yeah, from the parents. Well, so we have to know that nobody is born to be really perfect parents, right? And we have to also learn something.
Oh, thank you.
And what is the most common mistake, I would say, is something which is happening at the end of the first year of life, or maybe a little bit later, when the child is starting to walk. So because every parent is happy when the child is starting to walk independently, and if not independently, we are a bit pushing the child to do it with our help, which is not quite okay, because when we push him too early, he is using kind of different strategy comparing the situation when he or she will be doing by himself. So one of the mistakes it can be that we are holding the child by the hands when the child is trying to walk like a few steps in the space, in the like an independent walk, but because it's not still ready, it's not like a mature enough. So we are pushing him to do something which is not really set up already. So it can be a mistake, because then the strategy is completely different than he would choose as like his own way how to do it.
Well, I think one of the things that we really outlined over the weekend is the role that primitive reflexes play within development. And so one of the most common primitive reflexes that we check is the plantar grasp reflex. And so loading your child's feet before that plantar grasp reflex. Sorry, I'm having the moment here. Plantar grasp reflex
stroke.
is you're speeding up the neurology, and so this is supposed to be covered up by higher levels. And in turn, if you're speeding that process up, there's other consequences to that. What's the most common consequence you see, maybe that later on in life or within that first 2 or 3 years, if you do load their feet too early with walking and things like that?
Well, before I answer your question, I have to say that a lot of things during the development is happening in the right time because it's a reason for that.
Mm-hmm.
For example, when we are talking about the like a toe grasping reflex or plantar grasp reflex, so it can be vanishing or it must be vanishing in the moment when the child is starting to load the foot. And if this reflex is still positive, so it means also kind of like an irritation from the foot is doing like a flexion of the toes. So it's not possible for the child load the foot properly. And I think it's a little bit different, like also sensation from the feet, which goes to like a afferent, like a set of information, provide us such a good situation for the loading and for the gait development.
Mm-hmm.
So I think we have to also respect the, let's say, speed of the development. Every child needs his own time. And when we are talking about the time when the child is walking independently, so we are talking about like a 50% of children, they are reaching some like milestones. And some child, if even he or she is reaching this like a skill a little bit later, still it's a normal child, but simply it's lasting a little bit longer time.
Sure.
And it's not bad.
Mm-hmm.
Some children, so one participant from the course, he asked me, well, but my child was walking independently at the age of 10 months.
Mm-hmm.
Is it like a problem or not? And I said, no, when you look at the bell curve, so some of the children are a little bit faster, some a little bit slower, but still all of these children are in the norm.
Mm-hmm.
So the consequences when we are like pushing the children to do something a little bit earlier, it means that from some perspective, for example, the posture is not ready to provide such a good loading for the spine. And also some children, because they are clever, they are mentally a little bit like faster than posturally. So they want to more mentally than they can do by their posture. And sometimes it's then what is developing is, for example, infantile kyphosis on the back, because they want to be seated earlier, and the parents, they are put them into the seating position so early. And it can be another mistake what the parents are doing. They are putting into the vertical position so early, and it's not really good for the development of the spinal curve and the position in a vertical plane.
Well, and I mean, you showed the research that 50% of children are walking by 14 months is what you showed. And I made the point during the seminar that, I feel like in the Western part of the world, in the United States, like that would be, we're forcing our children to walk sooner. There's no way it's only half in our patient population. So I think part of the message is, there's no rush, and I think, like you were saying, the parents almost think it's like a badge of honor, like, oh, I have a very, eager child or whatever. And it's, so they kind of brag about that, which is, so yeah, whatever you can say to maybe, tell the parents that it's not necessary. And the in-laws are the worst, by the way.
Mm-hmm.
Sometimes it's a scenario like this that, the parents, and also sometimes like grandparents, they are doing a lot of mistakes because it's they want to help the child to do whatever the child wants to do, and they are pushing the child like walk independently, and once it happened, they are not so happy that it happened.
Then they gotta watch.
Yeah, it's another perspective. But what I think it's something it must be clear from the specialists, and this explanation that we have to, we should not push the child to do things which he or she is not doing independently by his own, like by his own strategies, let's say. So if someone is getting to the sitting position, that's fine.
Mm-hmm.
But if someone is like a 3-4 months, why put him or her into the sitting position? So he's definitely is not ready for that.
Well, and premature walking probably means that maybe you didn't spend enough time in like mature crawling, which is so important for development of the contralateral pattern. So can you speak on the point that, even if they are a little bit late, as long as they're in the right stereotype for crawling, how important that can be for establishment of?
So there are 2 points. One thing is when the child is not crawling too much or at all, and the mom is saying, well, he is not crawling at all, but he's already standing and walking around the furniture. Is it bad or good? So it's because he's so clever or skillful. And there's a 2 things what I want to comment. First is that if I see that the child is getting to the vertical position with all these components which are really good, well established, good position of the pelvis, good centrated position of the leg, he is using the contralateral pattern for the verticalization, I do not really care that he's not crawling too much. But if someone is really poor in a posture and he is getting to the vertical with a homologous pattern, so the both arms and over the both legs is going up with the anteversion of the pelvis, so it's not correct. So if I compare the correct pattern and incorrect, so this child which is not really good in this verticalization, he would probably he needs to have a kind of like a support and some facilitation by handling, for example, how to do it properly. But if that child, which is as mom is saying, well, he's not crawling but he's good in the vertical position and everything is okay, well, maybe he just chose his own like a strategy like this. And I'm okay with that he is not crawling, but he has all these components really well set up. So if these children, they are not crawling too much and they are poor, so what is missing is this training, what you said, this like a contralateral movement pattern, which is a physiological way of our locomotion. And I'm saying the parents that if the child is crawling longer time, it's really benefit for the child because he's really well established the skills when you are loading like a contralateral extremities, and you have to have in between really stable trunk with some kind of like a movement of the spine, etc. It is always good training before the moment the child is reaching the vertical and walking sideways or is cruising around the furniture.
Well, and if the whole goal of this critical period of development, this 14 months that we're talking about, is independent walking, that's why these benchmarks that you speak of in the seminars are so important to be paying attention to, because otherwise we're going to see a consequence down the road.
Yeah, definitely. When we see like an early verticalization and the child is in a vertical position with the ventral tilt of the pelvis, so and then is developing like a final like a double curve of the spine, so it's not good for the loading in between the segments, and it can be prerequisite for the problems in the future in adulthood.
So we kind of started with gait and walk, and we kind of went backwards. But if we're going backwards, then it sounds like 9 months is when we see mature sitting. So I think there's some research to show that at least in our part of the world, we're sitting our babies too soon, with a consequence of maybe how the physiologic curves of the spine are being developed. So that might be another thing to speak of. If we're sitting our babies too soon, then that also is problematic.
Yeah, definitely. So I have seen like a few children which they develop like a inverted curve. So they have like a lordosis in a T-spine and a TL
Me.
and TL junction or a lumbar spine is in kyphosis. So that's a question. What is real like a etiology of these problems, but definitely when you see this like in a sitting position, something wrong was happening before, because all these patterns, the milestones, which are like earlier in the development, influence all these patterns which are coming later. So in these earlier patterns are not good, so also it's difficult later to improve it.
Right.
Yeah. That's
So the problem with the sitting, I think usually because the children are starting to be able to engage, you know, especially like around the 4th and 5th month. So the temptation is to want to sit them up to like engage.
Yeah.
So then they're basically being sat way too soon.
Yeah. And what is also like a typical that these children or those children, they are really clever, like mentally, like a more developed than posturally, so they want to be in a vertical plane. Sometimes the mistake is when the parents, they have the children too much in a vertical plane really early, so holding them, or they have some like equipment all the time in a vertical, because the kids, they love it.
Mm-hmm.
And when you put them back in a prone position, supine position, so they're complaining. So, and what is a automatic reaction? They move them back to the vertical position and do because you want to make them happy. You don't want to see, or you don't want to hear they're crying or complaining. But this is also a bit problem when they have no enough time in the early stages of the development in prone position.
Mm-hmm.
So in some culture, so they the children, they are not placed into the prone position too much, and then we can see like a huge difference between the skills which are in a prone or supine position. So and then when we see, for example, when they we put the child in a prone position, and it looks like a 6 weeks child, even he's like a 6 months, and in a supine he looks like 6+. So it means there's a huge difference of the skills. And also, what is funny that when you want to improve it and you place the child at the age of the 3-4 months in a prone position very first time, they are screaming a lot. And because it's it's a panic for them, because they are not exposed to this position earlier. When you would do it regularly from the beginning, there's no issue at all. So, and what is the treatment for that? Sometimes I have to say that sometimes I'm telling to mothers, you have to buy the earplugs for 3 days and survive 3 days, and then it's done, because the child he really have to realize that it's not such a danger to be in a prone position, and they must realize what does it mean. There's like a sensation from the support sensation or information from the vestibular apparatus for all these segments, and then it's really they are happy in this position because they can see much more than from supine, and they are see and different a part of the world.
And how do you educate the parents? Because of course, no matter where you are in the world, people are concerned about we call it SID, sudden infant death syndrome, where basically there's so what is the recommendation to the parents? Like, you're still recommending not sleeping on your belly, and what is your recommendation for them as how much time on the stomach?
So generally when we are talking about the early stages of the development, so we really recommend to put the child like a quarter of the time in a supine, quarter left side, quarter prone, quarter right side, roughly. And we are not talking about this to put the child in a prone position and sleep there.
Right.
But when the child is not sleeping, because we want to push him or her to work in this position a little bit. So when he is not sleeping, so the mother will be talking to him, for example, and he will be in a prone position. So he must realize what does it mean to maintain the head in the right position and watch around. So, and this is a skill which is really important for this a spine development and also the development of the right a support, which is in the future really important for our crawling and the other skills.
In the formation of our spine curves the way our girdle joints are formed and all of that, which, I mean, people, they know tummy time's important, but they probably don't know like the reason why. Yeah.
And I think it's a maybe misunderstanding that we are not pushing the parents to let them sleep in a prone position, not really. And also, as I said before that, when they are sleeping in a prone position, they are not working in a gravity field with the body, and they are not uprighting or supporting actively, which is a kind of like a training in this position, what the body will need to improve for the next skills and next milestones.
And some of the postural reaction tests can tell us the kids that might be at higher risk for the SIDS and things because of the weakness and inhibition of the deep neck flexors. So there's some tests that could be done to see like if maybe kids are at higher risk potentially.
I'm not doing this like a test because no, I'm not doing this test for this like a risky situation. But when we are doing some like a assessment, we can see that these children, for example, they are really weak in a deep neck flexors, and they are using a lot of like extensors, and it telling me this is not like a proper coordination, which is which is important for the good coordination in this position. But me personally, I have no like evidence which test is really like related
predictor,
to this.
predictor.
Sure. So
right.
That's what I don't know.
You kind of spoke on it a little bit when we're talking about verticalization. How about the hip consequences from baby wearing? Education on hyperabduction, adduction, like where the hips lie when you are baby wearing, and maybe some of the consequences long term for that.
So what I used to say, the parents, it's not such a big issue when the mother has a kind of like a equipment for this position, and she's going 1 hour for shopping, visit the doctor, whatever. But in the cases, the child is like a almost 24 hours, 24/7 in this position. It is not really good for the hip development, and also this like a hyperabduction. It could really related to the hypoactivity of the abdominal wall. So and plus the third thing is, once the mother has the child in this position, in this equipment, almost the whole day, when he will be like collecting the like experience or from the prone position and work by himself, because he really needs to be in a prone. So so I do not really care if there's like a short period of time, which is really reasonable from some like specific reasons. But some mothers really, they need it a lot. They are using it a lot and a longer time, and I think that's not healthy.
Yeah, and I think just so the listeners know, like the face-to-face wearing is really what creates the hyperabduction of the hips. So if you can get it, if you want to do that, you're going shopping, things like that, having a face-away appliance is a better, it can have a better hip position. And just a neutral hip position is what we're aiming for. So
and also it's like a different type of devices. Some of them are really well tailored, and some of them the child is just hanging there and you can see how they are squeezing in a groin, and it's really not comfortable. And also some of them, they have no good support of the head if they are so early in this position. So so I have to say that it must be like a comment in this particular child. It's not easy to say like a general like recommendation, because it's really related to the age of the child.
Sure.
Yeah, because they could be too vertical too soon.
For sure.
Exactly.
Yeah, that'd be another problem. Which brings us to car seats, which is always, having two kids myself, I know when they were young, the car seats are almost too convenient at times. But you spoke about this weekend about having the right angle, which would be a 45-degree angle. And then maybe not getting too reliant on the car seat maybe would be or any other advice on that? Or
Well, this is similar to the strollers as well. Like there's like a philosophy that the younger the younger child is, the more support he needs, and also sometimes you have some special support also when the child is sleeping in a stroller or in a car seat from the side, when he is like dropping the head to some inconvenient position, oblique position, or especially when we have a child which can have some kind of like a issue after the birth, and he prefer some position, so automatically he's dropping into this position which is not painful or uncomfortable for him. So, and we want to like a little bit prevent that it's getting worse, or he is using it such a long time. So also it's a good to look if it's necessary in a stroller to have a child almost in a sitting position, even he is in a first trimenon. So in the beginning, definitely is it good to have a stroller flat and the child is in prone or supine or side lying, and it's completely okay and a safe.
right.
The best, let's say.
Beautiful. And then how about carrying the baby? I know that this is a big thing that I learned during this pediatrics course. And so, you know, it's been much debated and many debunked, but I think you have a good outline as far as outlines for parents or other people carrying babies, especially in that first trimester.
So, well, let's start with this situation when you want to lift the child from the table, whatever. So, which is not comfortable for the child when you are just lifting the child and a heavy head is dropping down. So, I think it's an intuition that everyone can support the head, but also what is a good trick that you are using also kind of like a rotational movement, which is really great. So then sometimes the mothers, they are saying, well, when I put my child into the prone position and he's crying too much, so it's not bad idea to put him on your forearm, and you can really have your child by yourself, and the child is more calm, and also it's a kind of like a training of the prone position as well. And the children, they are so happy. They are looking around, they are salivating a lot because they want to see everything around, and the child is happy.
Yeah, absolutely. And I think when they do start to have head support, lifting from the rib cage versus the shoulders would be another cue that I really took away from you as well. So utilizing the rib cage in a little bit of a downward position so that you're kind of cheating, almost getting some of that like abdominal wall activation would be another big one that I took away from you.
Also, I have seen some like approaches which they prefer to to have the child in front of the body, and they are flexing really too much the legs and the pelvis. And I don't think so. It's really comfortable for the child to squeeze the belly because of the internal organs, whatever. But sometimes they are like taught to put them into the scarf like this. I think it's not also good for the hips as well as for the belly. It's not comfortable.
Yeah, exactly.
And I'm assuming you're wanting, if you can, to switch sides. Yeah.
Oh yeah, that's also another point, which is like a typical for us, those are like a right-handed, we automatically put the child on the left hip.
So you use,
and automatically the child is taught that it's a good way to see in this direction. But when we trying to put it to the other side, it's like not fitting because we used to use just one side, and also the child wants to see here because it's taught all the time to be only on this side. So what is the recommendation? Try to switch it, but sometimes it's not really easy because you also by yourself, you feel it's not comfortable for you because you are more skillful when you hold a child in this position, which is trained.
Right.
So there's a bit issue.
I think this can turn into therapy too, at-home therapy. You know, if you have a predilection that's remaining out, like just switching the sides, it sounds so elementary, but it is so effective to make sure that it's allowing the baby to explore into that direction that maybe they don't like to. And so you're forcing them to do that. And I think that's a very good way of sending home therapy when you do have those babies that are like that.
What about coming through the legs with your arm like this? Is that...
you mean the prone?
No, kind of sideline. So...
Oh, a sideline.
Yeah.
This one.
Yeah.
Or the other hand.
Or going like through that way, or...
Okay.
Yeah.
So it's a different things what you have to do in this position, like which is something in between the prone and a side lying,
Right.
or between side lying and supine. So what I prefer to have a child here, because you have to a little bit support the head.
Right.
So when, especially for the children that are younger, or children they have a kind of like an irritation here, it's a really comfortable to support the head.
Right.
And when you have a this position here, you can easily use the both sides, because it's not such a big issue to do it like this. And definitely the child, even in the early stages, they have a predilection, so they prefer one side. But we have to also motivate them to use the other side as well. So that's and also that reminds me one thing. When after the feeding, it's also good to have a this position to let them burp here, and to also sometimes it's a good to have a this position of the arms, because the children, they have a support here, and when you help them be in this position, so it's really easy. And you can also be a little bit more oblique, which is not really perpendicular, but it's just for a while this moment.
And then the downside arm, go back to the way that you were going before.
Yeah.
Because sometimes you'll see you'll see the arm hang.
Oh yeah.
Versus the arm. Is that an important point or not so much?
Oh yeah. So when we have this position, which is something between the side lying and a prone, it's not such a big issue that the arm is hanging down, because you have a support for the shoulder here. Yeah. So when you want to talk with the child, so which is not correct when the arm is here. So but it is I think it's a normal, or everyone is doing it like this. Did we want to see that both arms are here and you have a contact with the child? And this distance, like 20-30 centimeters, is really the best what the child can see. So that's how the nature. It was done by nature, I would say, that is the best, because the face of the mother and the child. So it's during the breastfeeding, and the communication is really important.
Well, and that's what I was going to bring that point up, because you said that today. That is a really ideal position for feeding because of what you just said. Yeah.
Yeah, this distance.
Yeah.
So, and what is funny that when they did kind of like a research, and they put in the same distance, like the picture of the face, and it was not so easy to see for the child comparing to video. So when the mother is talking and moving with the face, he can really easily to see. So what is happening? So it's really important that the mother is talking to the child, as well as she's, smiling, whatever, and they have this distance between each other. Yep.
And you had some good tips on if you were changing the diaper, how saying you use rotation basically as you're transitioning them.
Yeah, because sometimes it's not quite convenient for the child when you are lifting, holding this around the ankle or around the feet, and lifting the child. It's better
and then power wash.
Yeah, and roll him to the side, clean, and then roll back, or for if it's necessary to the other side. It's more comfortable, and also the rotation is stimulus for all these oblique chains. So which is also kind of like a training a bit.
It's beautiful. Yeah, I think there's just so much clinical gold there. If you're listening to this on Spotify or on Apple Podcasts or anything like that, tune into the YouTube channel for the last 5 minutes of just watching Marcela work with the doll here. And so I think it's important, because these are the questions that come up in the treatment room a lot. What else can you be doing? And this,
or the jumperoos, those are no-goes.
The bumpos, all those things. Yeah.
And we kind of know that, and we assume that the patient knows that, but they actually think the opposite. They actually think it's good for their child to be on those things. So what's the danger of a jumperoo and thing? We know the answer, but someone listening might not. Yeah.
So these bouncers, especially when it's used really early, and for a long time, longer time than just for a while. So there's the same. So the kids, they are jumping there and they are not postural ready in the posture to maintain the right position. It is kind of like a facilitation. In a moment they can do it by themselves, but if you passively put them, so it's a too much load in the a vertical plane. And all these walkers, so we do not really recommend, or we do not prefer, because sometimes the children, they are placed really early into the walker, so they really don't know enough control, and they cannot stop the movement. Right. And they cannot stop by the hands, because in front of the walker can be a small table, for example. And what we have in our Republic, a lot of a cranial trauma, because the children walked towards the edge of the stairs and they fell down. So it was really danger, and it was prohibited by law some period of time to sell these walkers. But now it's
it's back on.
It's back on, and it's about the responsibility of the parents. And this is the same rule what I've been talking about at the beginning, that we do not recommend to push the child to do the skills which he or she is not able to do it by himself. So if he is not able to walk, why put him into the walker? Yeah, it's a nonsense.
Yeah, it doesn't make sense.
Yeah, it's beautiful.
And then other little tips that we've kind of glossed over. So let's just say the 10-month mark, where they're obviously crawling, they're starting to pull up. We're seeing hints of lateral cruising and things like that. Not having too ambitious of a pull up, not having that height too great for the child.
Yeah. So that's also another a recommendation to place the toys or into the right position, right a height, or so I'm pretty sure that we will not buy the new furniture, but some positions or some chairs, whatever, must be offer the child which is in the right height. So when the child is motivated to have something really high, so he's using inappropriate patterns, and it's not really good stimuli for the development. So that's there is one point what I want to say as well, that when the child is walking around the furniture, it's a really good training. And sometimes the parents are coming and saying, well, my son is walking almost 2 weeks around my table, and he'll be early walking to the space. And it can really last such a long time. It's no problem that the child is training this a side walking for 6 months, and this is okay because it's something new, and the brain must realize that it's okay to load the foot, to load the whole lower extremity, and one use as a closed kinematic chain, so for the support, and the other leg for the phasic step to the side. And also this training, walking in a frontal plane, is really great for the next development of the arches.
Right.
It's really nice.
And you recommend checking up on these babies. What are how often in that first year of life do you think that we should be checking up on them to do postural reactions, observing spontaneous movement? Obviously, we're doing primitive reflexes early on, but what are the key month marks that you think the baby should be assessed at?
You mean like a general screening?
General screening.
Okay.
Like a normally developing child.
Normally developing child. So, and who is doing the screening?
A DNS trained person.
Okay. So, what is our experience or protocol? We see a lot of from the spontaneous motorics.
Right.
So we know the milestones, and we also know how the milestones look like. and what is an ideal situation, and we can compare what is happening with the child, compare what we know what is ideal, like a ideal stereotype, let's say. Then we see some kind of like deviation, something which is not ideal. We can do the assessment of the reflexes, and but these reflexes are positive only in the early stages of the development, especially the first 4-6 weeks of life. So when we see the child a little bit later, so the primitive reflexes are gone if it's not like a central lesion, for example. But also, what is possible to do is to use the posterior actions, and when we challenge the child by this like sudden change of the position of the body in a gravitic field, so we can see the reaction which is corresponding also towards his age. And we can also see after this assessment of the posterior actions if the child has a kind of like a delay. So this is three parts of the assessment. When we put the data together, we can say if the child is developing like a risky child in a risk of not ideal development, and if she or he must be like indicated for the treatment. So this is what we can do after this like a screening.
So do you think it'd be fair to say somewhere between 4 and 6 weeks?
Yep.
3 months. Do you think 4.5 months, or can you wait to 6 months to start looking at the process of turning? Would 4.5 months be a good?
Well, the turning process, it's also, we are still back in the moment we are talking that when we say 4.5 months, this is for 50% of children, like statistically according to bell curve. Some children can do this like reaching over the midline at the 4, some of them 5.5, and still both children are quite normal.
So 6 weeks each way on the milestone.
Yeah,
okay.
Yeah. And when we are talking, for example, you mentioned the rolling or turning, so it's a starting to develop from the 4.5, and it's developing till the 6 months of age. So which is again the 6 weeks, and some of them they really are doing it too early. Some children they are doing some kind of attempts and then happening almost around the 6 months, and both is okay.
Right.
Yep.
Okay, so 6 months, and then I'm assuming you're wanting to check up on the quadruped crawling, so 9 months would be another good?
Yeah. Between 8 to 10.
Yeah, 8 to 10.
So because the time between 8 to 10, so we would love to see like 3 things: independent sit, crawling, and if the child is getting to the vertical, using this contralateral pattern. So this is also like a good point to check. So, or when we have a child which has a kind of like a small problems, and we finish this like a treatment, and then we invite or reassess the child in the moment he is reaching vertical, because in a vertical we can see how he integrated this like a new skills into this like a more challenging situation.
And if you ever come to a DNS pediatric seminar, you have made we call them the blue bubble slides that are so helpful from a learning standpoint. But then you also kind of go through like at this age, then these primitive reflexes should now be gone, which is really, really helpful. So the primitive reflexes early on, we obviously want to see if they're there and the strength of them, but then they're being covered up by higher levels of neurology. So it depends on when you're looking at the child to know like what exactly you're looking for.
So when these reflexes are gone?
Well, I'm just saying like as a point, to be like when we're assessing primitive reflex, we want them to be there at the right age, but then at some point they should be gone, so we can still be doing the assessment. But at that point, we're getting a completely opposite
that's
response.
true. Yeah, that's true. Because some reflexes we have a entire life, so we can see some of them. Some of them are vanishing later. So, for example, plantar reflex between 8-9 months of age, because this is the time when the child needs to start to load the foot for the verticalization. But also we have when we have a child which is a risky child, we can definitely try to assess some pathological reflexes to be sure that it is not, or it is like a central problem, central issue.
And then could you talk about like the continuum on not just a pediatric patient, but like our older patients where they have orthopedic injuries, let's just say shoulder impingement, and the central nervous system is kind of reverting back to this primitive strategy of stabilization, maybe not, of course, to the level that we see with like spinal trauma or brain trauma or cerebral palsy. However, like the utilization of the muscles is kind of the same way, just at a lesser point. So isn't that kind of fascinating to you? Like how when the joint system's in trouble, the central nervous system kind of
it's changing, right?
But going back to that original primitive strategy.
Exactly. So what is happening that because what is the explanation that when we have some kind of like a problem, so CNS like a switching off these most like a fragile and the latest functions which are coming in a development. So, and then there's a reason why when we have a problem with the shoulder, for example, our brain is pushing us to put the shoulder into the newborn position.
Right.
Because during the development from the newborn position, the child has a more external rotation, not so big elevation, etc., etc. And when we have a trauma here, whatever kind of, so we are losing this fragile like skills which are coming later in the development.
I just think that's one of the more fascinating things about the human body and its ability
The whole
to adapt.
development, whole development is fascinating.
Well, and I think it drives home the point of why these developmental milestones are important and why they're tried and true. You know, like it's hard to argue with them because we always say, like, it doesn't matter if you're born in the Czech Republic or in Troy, Missouri, you're going to go through those same milestones in a normal development. And the fact that the neurology is inborn and will revert back in crisis, it kind of drives home the point of why DNS and why developmental kinesiology is an important aspect of treatment.
You know, that is a one movie. The name is Babies, and it's a movie about like I don't know 6 babies from the different continents. So from Africa, Alaska, Europe, Japan, US, whatever. And they tape the children in the same time of the development and compare if the surroundings, environment is influencing the development. Yeah. And the main milestones were completely the same. It doesn't matter if the child was really strictly, I don't know, held and covered in somewhere in Germany, wherever. Comparing to Africa, the child is really early on the ground, playing with the dust and one plastic bottle, whatever. And they are reaching all these milestones in the same time. So this is something what we have inborn. I am pretty sure that it can be a little bit influenced by the experience of a child. But these like gross milestones are same for the human beings.
Right.
It's fascinating. Because you always make the point, Brett, when you teach a DNSA seminar, is like you have the video of a cow being born and the cow stands up and walks right away. That is completely different. You are completely dependent on your mother and your father in that first year.
Life's got to be relatively good for you to be able to.
Right. Yeah. And so I think that's one of the first things that really drew me to DNS is that the consequences early the development early determines the consequences late. Meaning the more your development is better, we'll say, or are on track, the more likely you are to not have these other kind of issues that plague Americans and the rest of the world, whether that be, like we talked about, spinal curvatures, or maybe too shallow of a hip socket, or too deep of a hip socket, or, et cetera, et cetera.
You know what I think it's a problem of these days, that in some countries this is a really hyper protective like a behavior of the parents, and sometimes it's really necessary to challenge our children to do some stuff by themselves, otherwise they have no experience.
Right.
I had a really like a weird situation. The child was a little bit sick at the beginning of the development, and the protection was so big that the family did not like let him fall down when he was like walking around the furniture, to realize how to control when he is falling back on his buttock. And because he had no experience like that, once he fell down, and it was really a big issue because he hit the head a lot. And when the children, they are learning from the failure as well, and if they have no chance to be challenged, so it's a bad for them, because we are growing by also all these things what we are not good in it. We have to change the strategy. We have to like do it in another way. So if we will do everything, and we are helping with a lot to our children to do whatever kind of you imagine, so I think it's not good.
I think if maybe just one closing point, one big takeaway I took with this weekend is I had you see one of my patients who was in the NICU for 2 weeks and was a little bit delayed, and hypermobility and things like that. But one of the big things that you were trying to convey to the parent is making the experience of treatment a positive thing. And so I think that it's very easy for us to, you go in, you ramrod, you're the doctor, you do what you got to do, and you get done. And instead, it's important to create an experience for the child so that they know they're going to exercise and they know when they're done. Can you talk on like how to create that experience? How do you educate the parent, and how do you do that?
Well, sometimes it's really difficult, because to feel when you see that your child is crying and you feel so sorry, so it's a normal, and it's an intuitive, it's an intuition, it's a normal for the parents. It is something also which is born. It's about
Protective.
these like yeah, absolutely. So, and it really works when the mother is really feel sorry that she is exercising the child, so the child can see it, can hear it, that she doesn't agree with that. And then then the child is crying much more, because he knows that she does not agree, and she will follow his crying if he will do it more and more. When the mother is saying, you can do it very well, like a sporty, like a intonation, so let's see what your belly is doing, and how about this, how about that, and she's talking to him with this like a calm but really like a clear intonation, not like a full of like these like emotions. So it's much easier. And this is a normal reaction when the child is going to be exercised and he is approaching the table, for example, he's a little bit upset. And when you finish this exercise and you are lifting the child up, the child is absolutely okay because it's finished. And when you are just putting them back towards the table, immediately see that he's again is upset. But this is a way of his communication, and this is also natural. Is it strange if some child is it really happy to be exercised? Because it's not our natural that we want to be exercised at the age of 3-6 months. No, we want to be with a mother, we want to be cuddled, so that's a natural. But because we are challenging them by this exercising, they have some new experience, and also they are growing by this also like a proprioceptive experience from the support, whatever, and then they integrate this like a basic patterns to their like motor skills or the locomotion or whatever he or she needs.
I think you said something too, and I've never actually heard you say it how you said this weekend that I loved. And I'm going to use it even in my adult patients, but you said you have to have a goal to your treatment, which is so intuitive, but like the way that you said it was so good. You were talking about the pediatric patient, which is basically if you're going to make an intervention, then there's got to be a reason you're doing that. And I feel like clinicians get in the habit of just, well, Marcela did this, so I'm going to do that, without like really understanding like why you're doing a certain thing. And I felt like the way that you worded that, I thought was so awesome. What is the goal? Because then you understand, and the kid understands, and potentially the parent understands why you're treating them.
Yeah. So I think it's I think, from my perspective, when you want to be a really good practitioner, so you have to be also like a fair or the honest to yourself, that you are able to say what is the problem of the child, and when you can point it, this is the first step of success. If you are just treating the child because the child is coming, it's not the goal. You have to say, okay, but they are coming because they have a problem with the support. They have a problem with the getting up. They have a problem with the crawling, for example. They have a problem with the feeding. And what is behind? When this is a problem with the crawling, maybe because he has no enough active ventral muscles, which must help the activate the trunk and maintain the trunk into the right position for the crawling. So, and the next step is to say, okay, how I can improve it. And this is a logical, like a consequence. And when you say, okay, I will do something because I have learned it in some courses, it's sometimes it works, but sometimes really not. And when you say, okay, the problem here, it was ventral muscles, then you did some kind of treatment and it was helpful. You are learning from the situation, and you are better because you know for the next child that it was good in the situation. And this is how we are growing with our skills.
I love that.
Yeah.
I think too, so the normal developing baby gives us some amazing opportunity to see what normal joints feel like, what the soft tissue should feel like, because everything's so neurologically perfect. And, you know, something that's been taught since the beginning of DNS is we're always comparing the patient that's in front of us to a normal developing baby. And I think that whenever people start to make it complicated, just go back to that, because then it really tells you exactly what you need to be working on.
Correct.
Yeah,
that's good. So, I think it's a perfect point to end on, one, having a goal in mind, and sometimes the goal is returning them back to that perfect synergy. You know, I mean, that a lot of times, especially in our patients that don't have overt physical trauma or overt physical illness, but maybe just a little bit delayed or maybe just a little bit not perfect here. And when you have that goal in mind and you can portray it to the parent, one, the parent's going to be involved and on board. And then two, it seems like the patient is going to be more on board too. Because if the parent is saying, this is a good thing, we need to take you here because we need to help with this, the baby's going to interpret that, and the end result's going to be amazing.
And you know what? Sometimes it's really helpful that you feel that, or you can see that the mom is saying, okay, I'm exercising my child, and daddy is not. He's not.
He's
on
drunk
the
on the couch.
One mother, she told me, well, when I'm exercising my daughter, he is putting the headset and the music loud because he doesn't want to hear how she's crying.
Dads out there, don't do that.
Yeah, don't be a dumbass dad.
I absolutely understand, but sometimes it's good to invite both parents and give some simple stuff to daddy to do it, to be also part of the team. And then it's not like a bad guy and good guy at home, and one is doing the bad things, which is mom is exercising, and one is saying, well, finally it's finished, come here to me, to daddy. So, and when they have some specific role, she's doing exercising and he's doing some part of the exercise as well. So it's better also for the child because he knows, okay, both of them, they are doing it, that's fine, because they know probably why they are doing it. And as I said, sometimes it's really complicated. Sometimes the grandparents are a little bit unhappy then when they hear that the mother is exercising and the child is crying, and they really knock on the door what is happening there. But sometimes it's not easy. I have also one issue when the neighbors in some flats, they call the police because something wrong was behind the doors and it was just exercising. So I think it's fair to to ask as well as mom as the mother or the father to cooperate and be on the board. Yeah.
Well, I think watching your evolution from knowing you as long as I have, I feel like you've gotten a little more lenient with what you'll accept from teaching the parents and you just got to start somewhere. And I feel like that is your gold medal trait. Whether you're teaching us or you're teaching the parents, it's not intimidating. It's, you got to start somewhere. It doesn't necessarily have to be perfect from the beginning. You got to get the process started.
Oh yeah,
so,
sure.
Yeah.
And once you start somewhere and you, for example, comment what is happening, you are talking about the plans and you observe what the child is doing, how the mother is, or the parents are how they comment what is happening around. It's some kind of information how tough you can be later. If they are a sporty, that's fine. And sometimes the parents are really anxious, and you can just the first session can do just a part of it, and that's fine. Don't push too much, and when you go step by step, so sometimes it's really effective not to push and not be so fast. So once I had a family, and the child was treated, and the mother said, "Oh my goodness, I don't know if I can do it." And then she came to the next appointment. She came with a grandma, or it was a mother-in-law, but doesn't matter, and her husband. And she said, "I am here to tell you that I'm not able to exercise anymore because he is crying and I cannot handle it. But I brought my mother-in-law and my husband, so please teach him how to do it. I'll teach them how to do it." And I said, okay. So, and I was teaching him how to handle the child. At the next appointment, she came again just by herself. And I said, "Where is the rest of the family?" And she said, "Well, when I've seen how he is exercising, I said, stop, and I'm doing that."
He'd been fired.
So sometimes they need a time, and they also need to have a chance to try it. Sometimes it looks worse than exactly is. And this is also my responsibility to say just enough information, not too much, not overwhelm that, to be able to say, okay, so now I did a good job at home. Because if I will say all the components, what we are discussing in between the specialists, it's a nonsense. They have two things, and they must watch, for example, I don't know, glutes and, for example, scapula, how it's moving together, and then we can continue. So, but first you have to show them that this is not a big issue. And also the children, when you repeat these exercises, so they're quite okay. So they are just complaining a little bit, but they know that this is a part of the routine. And I have one child, and he was exercised from his 20th day of his life, and when he was 3 years old, because it was meningomyelocele. Notice that?
Say it again.
Meningomyelocele. So not closed the spina bifida.
Oh,
okay.
Yeah.
Yep.
And when he was 3 years old, he said, "Oh, Daddy, we did not exercise today. Let's go."
Oh.
3 years.
Wow.
Because it was a part of his life from the beginning. And I don't know if the reason was, yes, something is missing in my program, but definitely he was better in his the pelvic floor stuff, etc., etc. And he was walking better after the exercising. But he was the one, he said, Daddy, we did not exercise, let's do it.
Love it.
Yeah.
You are what your parents' habits are. I think that's a big thing. But, well, in conclusion, I just want to say, Marcela, thank you for enlightening us. Number one, for sitting down with us, for putting up with us, for being here, for all the things. And I know it's been a little bit of a struggle getting you to Troy over the last couple of years, but we're so happy that you're here, and we're happy that you're coming back next year. You've already, you said your schedule's full, but you're still going to do it. So we appreciate that. So anyway, I just appreciate your education and the way you say things. And I'm just very thankful to have you on the team. We'll put it that way. So
yeah,
thank you.
Same.
Yep, absolutely.
Yeah,
so I think just the closing statement would be allow your children to explore, allow them to get into positions, and allow them to develop correctly. And if you're a practitioner, don't be afraid to intervene. Don't be afraid to say something about the development and check them and assess them and check up on these kids. And if you're a parent or out there, then you want find someone that's DNS certified to check them out to rule out these assessments and things like that.
It's the bedrock of DNS.
It is.
You always say, that when you saw the pediatric track really kind of turn some light bulbs on for you. So I think that, getting back to our roots kind of and understanding developmental kinesiology helps you also with your older patients that you're seeing.
Absolutely.
And,
It's not just baby exercises.
No.
Well, thank you, Marcela. Let's
Thank
go
you
get some
too.
food, and good luck with patients, guys. We'll see you next time.
Thank
Thank
you.
you.
I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.